to the demo.
This was really good. Welcome back to the second part of our Echo Starter course. In the first part, as you probably remember, we talked about the left ventricle and how to assess left ventricle function. And this actually sets you aside from many of your colleagues now, because now you will be able to quantify left ventricular function, an extremely important feature in every cardiac disease. But before we start, I want to review what we learned about the left ventricle function. And I would like to hand it over to Anna to tell us the features that I'm sure you didn't forget in the first part.
So we've imaged the left ventricle from parasternal, apical and subcostal approach. This is the cut from a parasternal short axis view. And here is the example. I'm sure you already recognize the difference between a normal left ventricle and an abnormal left ventricle, left and right respectively. You use the apical four-chamber view, and here again, normal against abnormal, really poor left ventricular function on the right, and you used subcostal, again, normal on the left, abnormal function on the right. You've learned to distinguish normal ventricle from dilated with poor function, like in this example, as well as from really small ventricle hyperdynamic in these other examples. In the context of left ventricular dysfunction, you also recognized wall motion abnormalities, like here we have an anterior myocardial infarction and here a lateral infarction. Now I think we are ready to go on.
The next topic we're going to deal with in the second part of our starter kit is aortic stenosis. Aortic stenosis is such an important topic because I'm sure you're going to encounter the disease somewhere along the lines in your medical career. Why? Because it's a disease that is growing in prevalence simply because our population is getting older. And it is also an important disease because we have new therapeutic strategies for these patients now. And if you learn how to perform echo, you will be able to not only diagnose these patients, but you will be able to determine which therapeutic strategy is best for them. I want to give you a few numbers that you understand the magnitude of the problem. Now, this is from a study where they simply counted how many patients were referred to hospital admissions for aortic valve replacement. And you can see that over the years, the number have dramatically grown. Now, this is in a Western country, in the US. And you can imagine if you look at other countries which are developing now and where the population gets older, you can see that these countries will come to the same situation, increasing numbers of patients with aortic valve replacement with aortic stenosis. And this is only the number of patients who were treated. Imagine how many patients are out there who we haven't even found yet.
Yes, and as a matter of fact, the prevalence of aortic stenosis in patients over 75 years has been estimated to be 12.4% and 3.4% in case of severe aortic stenosis. But I guess the most important thing is, aortic stenosis can really well present as emergency. And I perfectly remember a lady who came once to the emergency department because of syncope, and the diagnosis was made really fast thanks to echo. It was a case of severe aortic stenosis combined to poor left ventricular function.
Yes, and I remember a patient who came in with atrial fibrillation and with a rapid heart rate, and she was bound to get cardioversion until someone put the transducer on his chest and found out that it was severe aortic stenosis. Now, that really changes the management, doesn't it?
Are you still not convinced? Well, we interviewed some experts in the field of emergency medicine, and here is what they said.
In valve disease, you cannot go without echocardiography. Especially in aortic stenosis, you can immediately assess the severity of the stenotic valve, and you can see the left ventricular function.
Anna, do you hear this? This is aortic stenosis. This is a wonderful auscultation signal. Don't you think we can diagnose it with auscultation?
Yeah, Thomas, this is what a young colleague of ours actually told me once, that he could be faster with his stethoscope in diagnosing aortic stenosis than us with echo. The problem is that when you want to use your stethoscope, first you need silence around you. And in emergency department, you do not usually have silence. Second thing is, the intensity of the murmur doesn't usually correlate with the degree of the aortic stenosis. So the problem is you could overestimate or underestimate the degree when you trust only your stethoscope. And third, actually when you use your stethoscope, you do not know anything about the rest of the heart. When you are performing an echo, you know about the aortic valve and all the surrounding.
Yes, I agree. It gives you just so much more information. And to be honest, it's easier to see aortic stenosis than to hear aortic stenosis. And to prove that, we're going to show you lots of examples in this chapter. You know, when you perform echo, you don't really have a view of the aortic valve as it looks in 3D or in reality. And I want to show you a video which I think is spectacular that will show you how the aortic valve really opens and closes. This is a video that was performed or actually made from the University of Minnesota, which shows in an animal model how the aortic valve looks when it is truly perfused, when it is opening and closing. Now, you can see how tender actually these leaflets are. You see how they open and close, you see the three cusps, and you see that there is a line of commissure or of closure. Keep this in mind when you then look at the aortic valve on the echocardiogram. Here's another view. I think when you have aortic stenosis or some form of pathology, these leaflets will get thicker and they will be not as pliable as these leaflets, and the opening will be reduced. With this in mind, we will turn to the machine, to the scanner, and let us see how the aortic valve looks on the echocardiogram. You just saw some fascinating video images of the aortic valve. But in echocardiography, we see them a little bit different because it's a cut plane technique. And we can get numerous different cut planes. The first one we want to show you is a so-called parasternal long axis view.
Exactly, Thomas. We can really have a nice image of the aortic valve. Our patient, you can see as already his left arm under his head. It's important to get always good images. We put a transducer again on the left part of his chest. We are using the parasternal approach. You already learned about it in the previous section, but now we are using the long axis view.
Okay, Anna, stop. We have to show you exactly how to orient the transducer.
Exactly. So again, the transducer goes around second, third intercostal space, and the marker, the transducer, is now pointing at the right shoulder of our patient. So simply playing around, we get in a few seconds a really amazing parasternal long axis view.
So what are some of the structures we're seeing here? Or where is the aortic valve actually?
So the aortic valve we can really appreciate on top. It's the valve, we see two cusps and a line of coaptation, and the valve we see right below is the mitral valve.
Okay, and there's another important structure that we can see here that we want to discuss in this chapter?
Yes, exactly. This is a perfect view to visualize also the aortic valve and root together with the ascending aorta. And this is extremely important to have a full picture of the two.
Yeah, it's an important structure because there you will see a number of different pathologies, and you will also learn that the aortic valve is very closely connected to the ascending aorta.
That wasn't hard, but to make you really better understand, I would like now to go back to our simulator. And here we are now looking at the anatomy. The parasternal long axis view, as you can see, allows us to see a part of the right ventricle, the outflow tract. Then we really can appreciate the interventricular septum and the left ventricle. We have this tract here, which we will call the left ventricular outflow tract, because it leads to the aortic valve, and here nice visualization of the mitral valve. But now we are focusing on the aortic valve. In the anatomical part of our screen, you can understand why in this view we only see two cusps of it. And really nice, I'll tell you a trick. When you tilt the transducer like this, you can have a better view on the ascending aorta. So here and here, as simple as that. And now it's your turn. We selected 4 loops with aortic valve, Remembering what we've told you, consider the factors that you've learned, guess which one has aortic valve stenosis. I will show you the first loop in detail, so consider the thickness of the cusps, calcification. Do you think this is the one with aortic stenosis? It's maybe the second one. Focus on the aortic valve, opening and closure. Make your choice. I'll give you the third example. This is quite awkward, but do you think this is the case with aortic stenosis? Look carefully, and at the end, show you the last example with again another aortic valve. So, if you made your choice, we are ready to give you the answers. Of course, the valve which was stenotic is the last one.
But Anna, couldn't it also have been the one here? This one, doesn't that also look like an aortic stenosis here? I mean, there's a lot of echoes there. It looks calcified.
Yes, Thomas, but actually what you are seeing, it's something else. They are prostheses and rings. We will talk about them later on in our course, so don't worry for now.
Okay, so we tried to fool you. Not everything that is bright with echoes necessarily is aortic stenosis. And vice versa, there will be cases where the valve is not calcified, but it will still be stenotic. But don't worry. Usually if you have a patient who is over the age of, I'd say, 60 or 75, if he has aortic stenosis, the likelihood is extremely high that you will see calcifications. So that danger only persists in relatively young patients. But there's more to see in a parasternal long axis view. I want to show you a pathology which is closely linked to the aortic valve, namely the ascending aorta. If you look at this image right here, you will realize that not only is the aortic valve calcified, but we also have a dilated ascending aorta. We could actually measure it. And if it measures above 36 to 40 millimeters, we call it dilated. Here's another example. Now, in this case, the ascending aorta is even wider. Let's take a look at exactly at the shape of the aorta as well. You see that normally you have the sinus of Valsalva right here, and then you have something like the sinotubular junction, which comes from right here and extends to the ascending aorta. Now, both the sinus and the sinotubular junction, as well as the ascending aorta, is dilated here. Another example, again, a very, very wide ascending aorta and a relatively narrow aortic annulus. So all of these are examples of aneurysms of the ascending aorta, a very important pathology that you have to look out for, especially in emergency situations. Because, Anna, what can happen to them?
They can usually really easy dissect or rupture.
This is what you have to be looking for.
So coming back to the aortic valve, there's another view where we can visualize the aortic valve even better. It's the parasternal short axis view at the base. And I'm sure you want to see now how this echo view correlates with anatomy. Thomas, please, can you show us how to do it?
Yes, I will use the same approach that you've already learned, where we use the parasternal window. Now, opposed to looking at the left ventricle, however, we're now using a view which is a little bit more cranial at the base of the heart. How do we go about? Again, we take our transducer and we orient it to the right shoulder. So we're using the parasternal long axis view that we saw before. We put the transducer, get the parasternal long axis view, and then we simply rotate the transducer clockwise until we get a short axis view.
Oh, this is great. We actually can see the three cusps opening and a really nice tricuspid aortic valve.
Yes, you see the three cusps. And we usually say they look like the Mercedes star. This is how we check whether or not the valve is really imaged the way it should be. Some also say it's the peace sign.
Yes, actually, using the parasternal long axis and short axis, you get a really full view of the aorta and the ascending aorta.
Right, now you have all three cusps visible. You have the right coronary, the acoronary, and the left coronary cusp. But all this will come in more detail in the future courses. And now we'll turn to a few examples of normal and abnormal aortic valves. This is a normal aortic valve. Why do we know? Well, we see the cusps opening all the way to the root of the aorta. There is no calcification, and we have three cusps. Another example, this valve is a little bit more stenotic, I would say, or at least is a little bit stenotic because the valves do not open all the way to the rim of the aortic root, and there's a little bit of thickening. What about this valve? You can hardly see the cusps. Why? Because it's a young individual. And in young individuals, the aortic valve can be very, very tender so that you almost don't even see it with echo. And this is a valve which is heavily calcified. This is aortic stenosis. Take a look at that because that's what you'll be searching for in your patients. And now it's your turn. We have 4 examples. Anna, can you take over?
Yeah, we will show them one by one and try to detect which one has stenosis. Here's one aortic valve. Look at the cusps and motion. Here's the second example. Look at how the aortic valve opens and closes. And make your choice in the meantime. Here's the third example with again aortic valve, not really easy to say out this example, and the last one. So this is fourth and last example. Did you recognize the aortic stenosis?
Well, very difficult. Why? Because none of them have aortic stenosis. So we tried to trick you a little bit, but to be honest, none of these valves look like the one I showed you before. None of them have such a severe degree of calcification. You have to be able to differentiate the normal from the abnormal. However, beware, sometimes you can be fooled. As I already mentioned, especially in young individuals, even tender aortic valves can be stenotic. Now, one more example of a severe aortic stenosis. In this case, it was a relatively young individual, but you can see that part of the aortic valve is very strongly calcified. And this at least indicates that something is wrong with the aortic valve. Now, in the second part, or in the main course, we're going to show you how to quantify aortic stenosis. But at this point, I think it's important that you just recognize which of these valves have a problem and where you could suspect aortic stenosis.
Thomas, we've seen really nice examples of views and aortic valves, but is it always so easy to get these views?
Well, honestly, not always, because after all, it's a cut plane technique, and we have to sweep back and forth to find the area where you find the leaflets opening or not opening and where the calcification is. But Anna, I think you have something to show us, which is very spectacular.
I would like to show a 3D image of the aortic valve, which actually really resembles the aortic valves we saw already in the movies. So actually, I think this is really amazing what echo can give us in advanced course.
Yeah, I think it's just fascinating what this technique is able to do. Of course, this is something that you will maybe learn in the future courses that you might visit. But at this point, important for you is just to understand that the aortic valve is still a 3-dimensional structure. And when you image, you have to be aware of this and always scan back and forth so that you have the entire aortic valve in your field of view. That way, you will be much more sensitive with respect to diagnosing, for example, aortic stenosis or actually any pathology.
But I think it's time now to practice, and we have hundreds and hundreds of examples that we would like to show you, because you will always learn from books, but actually what you need is moving images, and we will provide you with all you need to learn. And here it's such an example. For instance, the key point here, you can hardly see the surrounding structures because the quality is really poor, but you can still distinguish aortic valve stenosis. Here, the same case, we are only looking at the short axis view, the calcification stands out, and you can make the diagnosis really easily. And the last examples for you, with again an stenotic aortic valve. At this point, I can guess you're really an expert in recognizing aortic valve stenosis.
Of course, the aortic valve is a very complex structure and you can find all sorts of different pathologies. But this is something I don't want you to worry about at this point. Important for you just to make the diagnosis of aortic stenosis. And, as already mentioned, don't forget to also look at the ascending aorta and detect dilatation of the aorta, which is often combined with the aortic valve. Well, I guess this concludes the second part of our Echo Starter Kit, and I hope you'll join us for our third part.
Yes, in the third part, we will talk about the second most important valve of the heart. It's a mitral valve, and we will talk about mitral regurgitation. Don't miss it.